Prostate cancer can be treated in many different ways. When it's localized to the prostate or has not spread too far afield, such as only to the lymph glands, then surgery and radiotherapy continue to be the mainstay of treatment. Traditionally, surgery was done by an open technique with a lower abdominal cut. But these days it's done by keyhole surgery, what we call laparoscopy, assisted by what's called a robot. But it isn't a robot, it's a very sophisticated piece of machinery which allows fine movements and massive and improved magnification. Just because you have that doesn't give you better results, but over the last 15 to 20 years, having introduced it into New South Wales, I found that the results have eclipsed even my best open results. And even in the last 1,000, from 1,500 to 2,500 cases, the results have continued to improve, both from a cancer point of view, from a recovery point of view, and from a side effect point of view. We never stop learning how to improve this technique. Admittedly, the machinery's improved. The current Da Vinci Xi is the state of the art and gives us all the advantages. But at the end of the day, it all boils down to how you do the procedure, how gently you do the procedure, what you spare, what you don't damage, and to make sure that you still remove the cancer effectively. So a typical patient now will come in, have their treatment done within 2 hours in surgery, be home within 48 hours, have their indwelling catheter out by day 6, be part-time back at work at 2 weeks and full-time back at work at 4 weeks, and by 6 weeks back to lifting heavy things again, and by 3 months any type of aftermath of any type of major surgery would have passed. This is a massive improvement compared to 30 years ago when the recovery was very slow and the side effects were very high. I'm now pleased to be able to deliver this type of treatment with extremely high continence rates and even high potency rates in appropriate patients. Having now done over 2,600 cases, I'm finding that I'm learning to select how to do the operation on an individual patient, whether to have my what's called functional hat on, which means I'm focused more on potency preservation and continence preservation as it's an early pickup of a cancer, or whether to have my cancer hat on, in which case, of course, the cancer is much more extensive, in which case cancer cure is the paramount thing, and we deal with any side effects afterwards. It's been a real learning experience to understand how to tailor the operation to the individual. Previously, we used to just think that you tailored the treatment to the individual, but now we actually tailor the surgery itself. And so as we get better at this type of tailoring, what we're finding is that the outcomes for individual patients are continuing to improve, even over the last 5 to 10 years, moving from 1,500 cases to 2,500 cases. So these days, how do I select a patient for robot-assisted removal of the prostate? The patient generally is a younger patient. What I call younger is less than 70 years of age. the patient has a cancer which is relatively contained within the prostate and a high enough grade that is worth treating. And if the patient, in addition, has difficulty passing urine, surgery is a very appropriate treatment as it treats both the urinary symptoms and the cancer. With the advent of focal therapy, which would be more suitable in slightly less aggressive and more localized cancers, surgery's developing a niche position for patients who have disease spread through their prostate but still have curable cancers. So as you can see, it's all about tailoring the treatment to the individual patient.